bachelor's to helping you prep for placement. And it's all for our virtual Freshers Fair, which has so much more to come. So remember to stay tuned on this Facebook page to learn more and get your content as soon as possible. So, I would like to welcome Marie, who's going to talk to you about prepping for placement and making the most of your placement, which is really exciting stuff. I wish I knew this when I was in your stages of first year, or even second year, or actually even third year. So, get ready for that. Remember to take your notes and join the Slack channel because Marie will be answering questions in there.
So hello everyone and welcome to my webinar series titled How to Ace Your First Clinical Placement. So this is part one and we'll quickly just run through the outline. So we'll go through a bit of an introduction about who I am and why I'm doing this series. And then we'll go straight into part one, which is all about assessing a patient and forming a differential diagnosis. When I've put out educational material in the past, I know a lot of preclinical students have said differential diagnosis is something they struggle with and that it's one of the things they worry most about going into placement. So I'm going to go into that in depth, but we'll touch on other aspects of assessing a patient. And then in part two, we're going to utilize the structure I give you in a case-based discussion or an OSCE-based format to really get you to grips with it so you feel comfortable using it. And then part three is going to be a bit more general, some tips I have for you for placement, some preparation before each placement that you can do, and a couple of things I really wish I'd known before starting placement. So, who am I and why did I make this session? So, my name is Marie. I'm a final year medical student at the University of Southampton. I took part in Southampton's Widening Access Scheme, BM6, so I'm always happy to talk widening access. I have an interest in medical education, hence why I'm doing this, and also acute care. The reason I wanted to do this series is I really wish I'd had more preparation going into clinical years. I felt thoroughly underprepared, and I think it stopped me from really accessing all of the things I could in placement and making the most of it. So I wanted to help you guys out and let you not make the same mistakes I did. And also with COVID, I think it's been more tough on you guys because you haven't been able to talk to your peers about any worries you have as easily, and you might not have had as much preparation going into placement as you might have liked. So let's jump straight in. So here's an OSCE situation. So Mr. Smith is a 30-year-old male. He presents to A&E with some chest pain and he looks short of breath and he's quite anxious to be seen quickly. Please take a history and formulate a differential diagnosis. So what I wanted to pull out of this in the first instance is, what do you think about? Where does your mind go when you read this? Do you instantly panic? Because I know I did when I was going into clinical medicine. You know, are you trying to pull things out of your head that you learned from a 9 a.m. lecture in first year? Or do you have a structure? And why I think a structure is so important is that when you are panicking or when you don't necessarily know the answers, you can always fall back on your structure and it will just help you work through and have a process. So that's what we're going to work on today. And this will be the case we use when we go into the case-based discussion later. So just to run through the classic structure of assessing a patient. So normally you would take a history, you'd examine the patient and you'd form a differential diagnosis. I find this quite problematic when you're first starting clinical medicine because you don't always necessarily know what to ask. You're quite scripted and tick boxing in what you're asking and you don't always know exactly why you're asking the things you do. So what I like to do is really think about my differential diagnosis first before I even see the patient, and just think, you know, someone comes in with chest pain or a headache, what should I be asking them? What am I looking for? What am I thinking they could have? And that's what we're going to look through in most part today. And then after you've got your differentials, you'll order some tests and you'll implement a management plan. So before we go into the nitty-gritty of differentials, I have a couple of tips for you history examination wise. So the most important thing, and I cannot stress this to you enough, is to practice. I've only got really comfortable taking histories and examining patients now, and I'm in final year. So the more you practice, just the more comfortable you'll be doing it. Get a fluent script as I've written. So a couple of the resources that I found really useful are Geeky Medics. I'm sure you've all heard of them. They do brilliant explanations of histories, and they do some really great videos of examinations. And just by really running through those and getting comfortable with what you need to ask is the best way to start. And then there's this book called OSCE Cases with Mark Schemes, which is the picture in the corner, that gives you sort of example cases like the one that I showed you previously. And it also has sort of histories, so that if you're doing it with a peer or something like that, then you can ask the questions and they have a script for what that patient has and what they'll answer to each question. And then you can look over the mark schemes at the end and think, you know, what would I get points for? What did I miss out when I asked? And what, you know, you can get really easy points that they'll point out for you. And then I've put in the bottom just what I sort of run through as a history, really based on what Geeky Medics do, but you can use that if it's a good starting place. I wanted to touch on some difficult questions. So I know I found it really difficult asking patients, do you smoke? Do you drink? Do you take recreational drugs? Asking them questions about their sexual health. I found them really awkward to ask. And when you feel awkward, your patient feels awkward. So one of the best things I can say with that, like with histories and examinations, is just to practice. Practice in front of your mirror, just getting the wording right, getting it to flow out right, and practice when you're taking histories from your friends. And they can all have a bit of a giggle with you if you word it weirdly or something like that. And it just makes it so much easier when it comes to talking to a real patient. And then always think, why am I asking each aspect? Why am I doing each aspect of an examination? What's it going to help me? What's it going to tell me? And that will really help you when you get into a situation of talking to a patient. So moving on to differential diagnosis. So I like to break it down into 3 steps for my structured way of thinking about it. So what I like to do is to think of a common presenting complaint. So like with our man in our situation, he has some chest pain, he has some shortness of breath. So they're good places to start. And then you want to go on to your differentials. So I'll give you 2 structured ways of thinking about this. One's a surgical sieve and one's system specific. And we'll go into those in detail in a moment. And then that will hopefully get you a range of differential diagnoses. And then when you've got those, you can start thinking, what questions am I going to ask? Or what am I going to do in my examination to help me rule in or out each differential? And you can do this before you've ever even seen the patient. You can start thinking about all these things. And then it really just helps prepare you so you're not completely, out of the blue, not knowing what you're doing. So the approaches that I said previously, you've got surgical sieve and system specific. Surgical sieve, so I had this term thrown around so much in my first year in clinical placement. And for the first few times, I'll be honest, I had no idea what it was. But it's basically a way of thinking about what differentials you can think of or what causes there could be for someone's symptoms in a structured way. So like I said, you're not just picking things out of your head. So if I give you an example for this, so say someone comes in with a headache, you can work through this and really think, okay, what could be a vascular cause for that headache? And you can think maybe, okay, maybe a stroke, ischemic or hemorrhagic. You can go, infective, maybe meningitis or encephalitis. Or trauma, you can think if they had a head injury, if they had a fall. So like I say, you can go through the whole thing. And it's a useful acronym. We love acronyms in medicine. So it's just a way of working through it. The second way is to think of it in a system-specific way. I personally find this one a bit easier because I'm quite a visual learner, so I like to be able to imagine all the different systems in a patient and think, okay, which one's gone wrong? But it's much the same. So you can think of the cardiovascular system for a headache and think, have they had a stroke? Have they got atrial fibrillation? So they flowing off loads of clots that are going to the brain. And you can work through the systems like that. So I've made a couple of tables for you guys to use. This one's one for surgical sieve, and there'll be a link to them below so you can download them and use them. But like I said, you can just fill these out. And then there's a system specific one. And I prefer this one too, because I find it easier to break up into things that are life-threatening, things that are urgent, and things that are non-urgent. And like I said, I love acute care. So this is so useful in A&E when you're thinking, what do I need to rule out right now? And what's going to kill my patient first? So yeah, this is really, really useful. And you can find them below when we go into part 2. So we've got the common presenting complaint, we've got our differentials with our 2 systems, whichever you prefer. And the third part, like I said, is the questions to rule in or out each one. So what I try and do is for each differential, I try and write down 3 or 4 questions that will help me either sort of like think, yeah, this is what this patient's got, this is what I should investigate more, or no, actually, I can get rid of that differential from my thinking for a while. Know why you're asking each question. And you can use Socrates, another acronym, as a starting point. I'm sure you'll have all heard of it, but it's just an acronym for a way of assessing pain in the patient. And then once you've asked all these questions, you've hopefully got down to a couple of things you're really focused on, then you can go through tests. So my way of thinking about tests are in 3 different categories. Again, I love structure. So the first one you can think of as bedside tests. And these are quick, simple things you can do at the bedside, aptly named. Things like a urine dip or an ECG or blood glucose or a venous blood gas, things that you can do quite quickly that will give you quick results. Then there's lab testing. So with this, I mainly mean bloods. So things like a full blood count or USANEs or LFTs. And then imaging. So things like ultrasound or an X-ray or MRI or CT. And what I want you to think about as well is the timings with these. This is something you'll come into more when you start placement, but it's so useful to think about, how long will this take? And can I get an answer quickly using a different test or something like that? So as I said, bedside tests really quick. Labs, depending on where you are in the hospital, can be sort of an hour, can be a couple of hours. And with imaging, or you can get a chest X-ray relatively quickly. But if you want an MRI, you're going to have to plan that in advance. So maybe not as good for your acute cases. Another point is to have an idea of the normal values with your tests. So have an idea of what a normal hemoglobin is and what a normal CRP is. Or, just so when you do then get your results back, you can say, actually, this one's abnormal quite quickly without having to flick through or look it up on your phone or something like that. And then always thinking with tests, will it aid my diagnosis? Will it help me? Will it change my management plan? And if it's not going to change your next steps with your patient, then you probably shouldn't be doing it. It's something that a consultant once told me. So that's definitely stuck with me. So that's really the end of this first part of the series. Hopefully that's given you a bit of a structure to thinking about forming a differential diagnosis and assessing a patient. And in part 2, we'll be talking through a case and how you can use the structure to sort of start thinking about differential diagnosis. So this video was made possible by the Brilliant Medics Academy. I took part on their virtual elective and it was amazing. I would 100% recommend taking part in it if you're interested in medical education. There's also a range of videos coming out on this YouTube channel by my colleagues who are doing a similar thing, like a couple of series that you should definitely check out. And on the Medical Academy's website, for any medical students out there, there's a part called SDocs, which is designed just for medical students with some brilliant content. So hopefully you've enjoyed this and you'll join me for part 2. Thank you very much.
Now that you can assess a patient and form a differential, Marie's going to show you how to use that in a CBD. Take it away, Marie.
Hello everyone, and welcome to part 2 of this series on how to ace your first clinical placement. So in part 1, we went over a structure of assessing a patient and formulating a differential diagnosis. And in this part 2, we're going to try and use this structure in a case-based discussion, to try and run through and work it out. So if you haven't seen part 1, it might be useful to have a look now. But let's get started. So we've got the same situation as from the first one, which we're going to run through. So Mr. Smith, who's a 30-year-old male, he presents to A&E with chest pain and he looks out of breath and he's anxious to be seen quickly. So please take a history and formulate a differential diagnosis. And like I said in the first video, this is something that's really realistic, could come up in your skis, and it'll be really useful to have a structured way of thinking of theory. So I've used the system-specific method to give you an example because I found it easiest, but if you want to use the surgical sieve, then it's more than fine, and it'll be a similar run through. So using this table, I want you to try and think up as many differential diagnoses as you can for chest pain and write them down in this chart or just down on some piece of paper. So if you want to pause the video now, then you can think up as many as you can, and then we'll run through some of them. Okay, so here are the ones I came up with some help from Dr. Google. That's very much allowed. And don't worry if you didn't get all of these. This is quite extensive and covers, you know, a lot of different areas. But if you got some of them, then brilliant, well done. So I've obviously come up with these lot, and what we'll go through now is we'll pick out one or two, and then we're going to try and differentiate between them. So the ones I want to really differentiate between are two of the life-threatening ones, probably the most useful. So we're going to try and differentiate between an ST elevation MI, which is a myocardial infarction that has infarcted enough of your heart to give you an ST elevation on an ECG. Not a great position to be in. And a pulmonary embolism, which is just a clot in your lungs. Equally, not a great position to be in. So now I want you to try and think of some questions you'd be asking your patient to try and differentiate between the two. And then maybe the answers you'd expect them to give you that would point you in either direction. So again, if you want to think of 3 or 4 questions, you can pause the video, write them down, and we'll run through the ones I've come up with. So yeah, pause if you'd like. Okay, so here are the ones I came up with, and they might not be the same as yours. Don't worry about it. There's a million questions you could ask, but I came up with some just generic ones. So for an ST elevation MI, I thought you could ask about the character of the pain. And by character, I mean, you know, is it sharp? Is it dull? Is it achy? And the answer I'd expect back, a really classic answer for a STEMI, is crushing chest pain. So that people will say it feels like someone sat on my chest. So crushing chest pain, often radiating to the left arm and jaw. And this won't always be the case, but this is if it does come up and your patient tells you this, you know, barn door MI. The location of the pain. So I'm sure you all know, central. Usually people say, you know, it feels like someone sat right in the center of my chest. And there's actually a sign for this called Levine's sign, which is where patients, when you ask them where the pain is, they put a fist and they put it over their sternum and they say it's here. You know, it's right in the middle. And it's been shown that a lot of patients actually do that when they're having an MI. So then I would ask about some associated symptoms, and some of the ones I'd be thinking about with an MI are maybe some nausea, some vomiting, some shortness of breath. Patients often get a cold sweat, some grey skin, and they also sometimes talk about an impending feeling of doom, which sounds dreadful to be honest, but they get this feeling that something really bad's going to happen, because it is. And then some risk factors. So this is more something that you'd pick up running through the history, but when you ask things like about smoking and drinking and family history and bits. Just a couple of the ones I came up with: smoking, advancing age, being male, unlucky all the males in the audience, obesity, leading a sedentary lifestyle. So a really common example is a lorry driver who only eats takeaways. Having high blood pressure, having high cholesterol, there's loads of them, but these are things you can pick up and go, okay, you know, this makes it more likely it's going to be this. So I like to think of Adam Levine for my Levine sign, and smoking. Now, if we move on to a PE, pulmonary embolism, I've picked the same 4 questions just to prove how easy it is. So the character of the pain for a pulmonary embolism. Classically, sharp and pleuritic. Your patients won't tell you that it's a pleuritic pain unless they're a medical professional, but they'll often say, you know, it's quite a sharp pain that's quite constant, and it's worse when they breathe in. Location of the pain. This is variable depending on, you know, the location of the PE and what it's affecting. Associated symptoms, so shortness of breath is going to be a main big one up there, but also DVT symptoms, so deep vein thrombosis symptoms, things like having a swollen red tender calf. And it'd usually be on one side, but people do get bilateral DVTs, so that's something to be aware of. But that will definitely be, if you see someone with the kind of DVT symptoms, you're definitely thinking, you know, and they're short of breath, could they have a PE? And then risk factors. So and again, another classic exam example is a recent long haul flight. That will always come up. Or they're in a hypercoagulable state, so like pregnancy, you're so much more likely to get clots. If they have a clotting disorder like thrombophilia, they've had recent surgery, I'm talking like big surgery that leaves them immobile, like maybe some orthopedic surgery. The combined oral contraceptive pill makes you more likely to have clots. Things like smoking or having a malignancy makes you hypercoagulable. So this is an example of a DVT. You see your red hot swollen leg and recent long haul flights. So to run through some tests now. So I won't go into this in too much depth. This is just, you know, an add-on adjunct. But like I said before in my first video, think about a structured way of thinking. So the bedside tests you might do are an ECG. If you do an ECG and you see a barn door ST elevation MI, you're thinking easy, easy peasy. An ABG will show you a bit about, you know, lactate levels and the oxygenation. Lab testing, these are some classic ones everyone gets in A&E, you know, your full blood count, your Usenes, your LFTs, your CRP. But then some extra ones for this scenario. So a D-dimer might be useful. Generally, a D-dimer is more useful for ruling out a PE. If you say to a consultant, I'm going to use a D-dimer to rule in a PE, they will not like you very much. It has a high negative predictive factor, but not a good positive one. And then some serial chops. So obviously, if they're then raised, you're thinking more of a cardiac cause. Imaging, so a chest x-ray, like I said, you can get it quick. You can rule out things with chest pain, shortness of breath like pneumonias, and bits like that. And a CTPA, so a CT pulmonary angiogram to look at the blood vessels in the lungs to obviously see if there is a PE, and that's gold standard for looking at that. So hopefully that's useful. We've run through pretty quick a way of looking at chest pain, differentials and that type of thing, and then how we differentiate between them with some questioning. So what I've done here is try and compile a list of common presenting complaints you might come across, especially in OSCE situations. And what you might want to do is maybe take a picture of these or write them down and then try and work through the method yourself, and trying to differentiate between each one using each symptom. We've gone through chest pain, but equally you can go through all the differentials coming up with different questions, and I hope that they're useful. As I said before, this whole series would not be possible without Medic Academy and their brilliant virtual elective. If you're interested in medical education, I would highly recommend their virtual elective. I enjoyed it so much, and obviously it means I'm here talking to you guys today. If you're, hopefully you're a medical student and you want to access more things like this, then my colleagues are doing a lot of videos on this YouTube channel similar to this. And if you go on the Medics Academy website under SDocs, there's so much information for medical students that you'll find useful. And if you're interested in part 3, we're going to be running over some general tips for placement, some preparation before you start each placement, and a couple of bits I wish I'd known before starting placement. So if you're interested, then the link is in the description below. Thanks for listening, guys.
Since you guys are just about ready for placement, Maria's gonna get some top tips so you guys are in tip-top shape when you get onto those wards. So let's hear what she has to say.
Hello everyone, and welcome to part 3 of this series about how to ace your first clinical placement. This part's going to be a little bit more chilled, a little bit less work intensive, so probably good to watch if you're a little bit tired. So this is just where I'm going to give you a couple of tips for placement, a bit about the preparation you can do before each aspect of your placement, and some things I really wish I'd known before I started, so hopefully I can impart some knowledge. So I really found it difficult preparing for each individual placement, especially at the beginning, to know what I should be looking up, or like what would help me in that placement, especially if you haven't had much clinical experience prior to med school. So a couple of things I want to point out to you is that the first one's that common things are common. So my GP once said to me, when you hear hooves, think horses, not zebras. So um, look up the common things that come up on your firm, and they will come up endlessly. Um, the next thing to mention is about specific histories and examinations. So if I give you the example of my first placement, which was colorectal surgery. So on Geeky Medics, if you go on there, they have specific like gastrointestinal histories and abdo examinations. And those are the things that put you in good stead for when you're talking to patients on a colorectal ward or, on GI, because there are specific things you need to ask alongside your normal history. And then when you do go present to your consultant or your reg or the F1s, and you say, they haven't had any diarrhea, they haven't been vomiting, or they haven't had any abdo pain, they're then thinking, oh, this person knows what we're talking about. They know what to look for, what not to look for. The next thing I want to say is about conditions. So really common conditions you need to know about, not in any great depth. This is not saying that you need to spend your whole weekends revising for your placement, but just to give you an idea if you want to look through. So to give you the example of the colorectal ward again, some of the conditions that come up constantly are things like Crohn's and ulcerative colitis, colorectal cancer, and it's not saying you need to know loads, but just a little bit about what each one is, what causes it, and the treatments. A bit about procedures. So obviously on the surgical ward, know a lot about bowel resections, about colonoscopies, just know a bit about what they are, what happens, and that will put you in good stead. Some guidelines to look through. So this won't be applicable to every single placement you're on, but if there are some really like exam heavy guidelines, things like asthma care pathways and escalation type thing, then that will be useful. Different screening protocols. So this is in my head again from this first placement, where I was in colonoscopy with my supervisor, and my first ever week on placement ever, and he turned to me in front of the patient and said, Marie's now going to explain to you what the colorectal cancer screening program is. And I was, I just stood there and thought, this is crazy. Luckily, I'd done my project in colonoscopies and resection of polyps, so I did know a little bit about it. But just in case, I'm not saying every consultant puts you on the spot like that or trying to scare you, but if there is a really obvious screening program, like breast cancer screening or cervical cancer screening, then just have a look up and know who they screen, what happens at the screening, that type of thing. And then a brief note about the difference between medical and surgical firms. So this is really general, and so by no means exact, but I found personally on medical wards, they're more interested in the pathophysiology of disease, and obviously the medical management of it. They're much more keen on your histories and your examinations, and that type of thing. Whereas on a surgical ward, they're much more keen for you to know the anatomy. Obviously, history and examination is important in both, but they're much more keen on the anatomy, and knowing about the procedures, looking into a bit about the surgical prep and that type of thing. So it's just having a think about what you're about to go on to and what they're going to be looking for from you. So what I wanted to run through also is a day on the wards, because when I first went into placement, I hadn't had that much experience in hospitals, and I found it really daunting to sort of know what was going on. So hopefully this will give you a little bit of an idea. I realised this one that I put on is quite medicine heavy, so this is more like a medical day, but the most important thing is to get to know your own wards routine. So even just ask someone, what happens in the afternoons? What can I get involved in? What time does the ward round start? And ask how you can be involved. So in the morning, there's usually a ward round. Prior to that, they'll probably talk through every single patient before they go on. So find out what time it starts, get there a bit before, and find out how you can get involved. Some of the easy ways to get involved, really, really simple things like making sure that you've got the patient's drug chart for the doctor to look at, or pulling around the curtains, or when you get a bit more confident, you can sort of say to the doctors, oh, can I have a look at what you've written in the notes? Get an idea for how they like the notes written. And then maybe you can prepare a patient for the next ward round and you can write in the notes. Really just be enthusiastic and people will be keen to involve you. So after the ward round, they'll write a jobs list usually. This will be things like bloods for patients or organising scans for them. And that's another thing you can get involved with. So if you let them know, could I take their blood from that patient? Could you show me how I'd organise a scan? And then, for when you're in F1. And then plus or minus bleeps. So if you have someone that's on call, they might get bleeped to go and review a patient or another ward. And you can ask, oh, can I go along? And you can see someone with a big amount of experience as first assessing a patient that's coming onto your ward, and really get a feel for the questions they ask, what's important, and then how they present it back to maybe a consultant or something. And then discharge summaries. This either happens in the morning or in the afternoon, depending on how your ward runs. But discharge summaries are the bane of everyone's life. And if you can get someone to kind of get involved with you, teach you how to do them, they will love you forever for offering to do a couple of them for them, which means they'll hopefully have more time to teach you or, to help you out. And really, really useful because you spend a lot of your time as an F1 doing discharge summaries. And then in my experience in the afternoon, it's a lot more relaxed. There's a lot less going on. Obviously, if you're in surgery, it might mean there's surgeries then. But I find the afternoon's a really brilliant time to do your histories and your examinations on the patients in the ward. So ask your doctors, but also ask the nurses, who's a good patient for me to see? You might have spotted one on the ward round, but if not, you can ask, who's friendly, who's well enough to have a chat with me, who's got interesting signs, or, who's got a good murmur, or, that type of thing. And they'll be able to help you out. And it's a really good way to sort of improve your skills. So I am a really awkward person. And I hate the feeling that I'm just sat there with nothing to do. And unfortunately, this does happen occasionally, maybe more than occasionally, as a medical student, that there isn't actually that much going on. And I have made this plan for you so you don't feel quite as awkward as I maybe did for the first few placements I had. So the first thing, like I said, is ask to see patients. There's always patients around, and usually they're more than happy to have a chat with you because there's not much going on in hospitals. Discharge planning, like I said before, you can shadow the F1 on call, and that will give you a really good idea of what you're going to be doing when you first qualify. So that's a really good thing to do. You can look through patients' notes. This is something I like to do. I liked it a lot more when I sort of first started because it gave me an idea of the progression of a patient through their journey in the hospital and how people clerked them, what they sort of acted upon. So you could look at when they first came in and think, okay, here's what they presented with. What questions would I have asked them? And then based on the history, read through the history, what do I think is going on? What tests would I have ordered? And then you already have, on the other page, whatever, oh, what tests did they order, the doctor? And why did they order those? And then you're already learning without even having to see patients. And then maybe look through, the sort of treatments they got for their conditions. It's just something you can do without there having to be a constant stream of patients coming in. You can review some drug charts. So I find it easiest to learn medications when I put a face to the medication. So if you're talking to a little old lady who has heart failure and she's on furosemide, have a chat with her about how she finds, taking the furosemide. Does she find it makes her really dehydrated? Does she have any side effects? And then you can it builds it up in your mind more than just reading it in a book or on Google or something. You can attend scans or procedures with patients, obviously ask, but that's a really good thing to do. And utilize your nurses. I cannot emphasize this enough. Nurses run the ward. They are always there. They're always chatting to patients. They have way more time to spend with patients than doctors do. And they will know their patients inside out. They'll know how the ward runs. They'll know where everything is. they are so fantastic. And if you are kind to them, you're nice to them, and you treat them with respect, they will give back to you in wonders. So maybe on a slightly deeper note, a few things I wish I'd been told before starting placement. Imposter syndrome is a real thing. And in my experience, medics don't really like to talk about awkward or embarrassing things. But sometimes, things don't go well in your day and you start thinking to yourself, actually, am I actually supposed to be here? Have I got the knowledge that I'm supposed to have? Am I just blagging it? Are people, but everyone feels like that at some point. Everyone. If you've read Adam Kay's book, he feels like that all the time, even when he's going up to, the upper levels of registrar. So talk about it. Talk to your friends, talk to your peers, talk to your family, talk to anyone and everyone about it, and normalize it for yourself and for others. You'll thank yourself for it. It's okay to not know everything. This is something I wish someone had told me. You don't have to know everything at all. No one expects you to. I'm in my final year. I don't know anything. I don't know everything by a long shot. And no one expects you to know everything. As long as you're willing to learn, that is fine. Acknowledge what scares you most and tackle it early on. So a little bit of an anecdote. When I started clinical placement, I was terrified of doing cannulas. Terrified. It was more actually about, when do you wash your hands, when do you clean everything, and rather than the actual practice of doing the cannula. But I was terrified, so I completely avoided them. For the whole of my first clinical year, I avoided cannulas. How ridiculous. And then it got to OSCEs, and I think it was the third or fourth station along, I saw the brief and it said, this is a cannulation station. And my heart just dropped. I was terrified, but I did the station and it was actually one of my highest ranking stations. This isn't saying ignore things and they'll be fine. This is me saying that I was terrified about it, so I avoided it. And actually, once I did it, it was fine. So acknowledge the things that scare you and then tackle them and think, what, I'm just going to do it, because if you don't, then you'll be worried about it forever. Another thing is that patients are just humans. They're just humans just like you. I used to be terrified of talking to patients. I used to think, what about if I say the wrong thing? What about if they know I don't know what I'm talking about? But patients in general are lovely. They love having a chat with you. They're more than happy to tell you about their experience with their medical conditions, with drugs. Be comfortable with them and be polite, be nice to them, and they'll be more than happy to have a chat with you. And the final thing is just look after yourself. Medics, we are awful at looking after ourselves. We all look after everyone and anyone before we look after ourselves. But you can't help others until you look after yourself and make sure you're okay. If you're going through struggles with mental health or anything like that, then make sure you get some help for it, you get some support, and look after yourself is really the main thing I wanted to say. So in summary, we've gone through all of these different things in these series. So we've given you hopefully a structure for assessing a patient. We've gone through some approaches to formulating a differential diagnosis, which I hope are useful. We've went through an example of this in a case. I've given you a couple of tips for placements, a little bit of a structure of how the ward runs, and some things I wish I'd have known, and a bit of a to-do list for slow moments on the ward. So I really hope that this series was useful. I know how scary it can be going into clinical placement, but you will be fine. Honestly, as long as you're enthusiastic and willing to learn, you will be fine. So if you have any questions, please direct them to me, Marie. That's my email there and my Twitter handle. One really important thing I want to say is I'm so thankful to Medics Academy for letting me on their virtual elective, for always supporting me, and for making this series possible. So if you're interested in a virtual elective, they are running them still now. You can apply, and I could not recommend it highly enough if you're interested in medical education. Also check out a lot of the other videos on the Medics Academy YouTube channel. Many of my colleagues are doing similar videos, and if you're interested in more content like this too, then on the Medic Academy's website, they have the SDoc segment, which is specifically for medical students and has loads of great content on there. Thank you so much for listening to this series. I really hope you found it useful. Thanks, guys.
Now that Maria has done such a great job, we're going to be moving on to Khalid, who will be teaching about orthopedic fractures, a topic that any medical student should know about.
Okay, so hi everyone. My name is Dr. Al Hashimi. I'm a recent graduate doctor, 2020, and I have a special interest in orthopedics. So today I'll be teaching you about orthopedic fractures. If you'd like to see some of my colleagues' lectures that they are producing, do click on any of the other videos on this channel. This is a short web mini-series consisting of 3 parts. This is the first part, so feel free to click on parts 2 and 3 to continue with this mini-series. If you are a medical student, sign up to the free SDocs program, which you can do so from the link in the description to the video. Right. So what will we be covering today? Today, I'm going to split the lecture into 3 parts. The other part 2 and part 3 will be part of another video. The first part we'll be looking at today is the general principles of fracture classification, clinical features, investigation, and the management of fractures themselves. So, part 1. What is a fracture? A fracture is a loss of union of a bone or a loss of continuity of a bone. So if there's any disruption to continuity of a bone, we refer to it as a fracture. There are 3 key causes to any fracture. The first one being trauma to normal bone. The second being stress, so repeated stressful forces or low velocity kind of forces, which are acting on the bone, causing fractures. And the third one is disease, so to pathological bone. Examples of this would be osteoporosis, which is a state in which there is reduced bone density, particularly seen in elderly patients, bone sarcomas, which are primary bone tumors, and metastases from other primary sites, such as prostate or breast, and Paget's disease of the bone. Right. So how do we classify fractures? So the way in which we classify fractures is there are multiple different ways, and there's no specifically set way. However, these are a set of examples in which orthopedic surgeons or other doctors generally tend to follow. So first one would be anatomical location and position. Second would be the extent of a fracture. Third would be the orientation of a fracture. Fourth would be displacement of the fracture. Fifth would be fragmentation of a fracture, and 6 would be soft tissue involvement, which we'll discuss further in just a moment. So to begin with, let's take a look at anatomical location and position. So we understand with every bone, generally the way that we refer, if we start looking at the anatomical model with a man with palms facing forward, is that we have proximal and distal. Proximal generally means closer towards the body, and as we move further away the body, for example, down the arm, or down the leg, we would refer to it as distal. So fractures can be classified anatomically based on location or position. So if we were to take a look at anatomical location of the bone, we would say proximal versus distal. Proximal would usually be within the first half of the bone. Here is a picture of the femur, and you can see that the proximal generally tends to go halfway along the diaphysis before terminating, or before that we start referring to it as the distal portion, which is the second half of the bone. Second one would be the second way in which we classify is anatomical position. So the way in which we generally tend to classify long bones is using 3 key terms: the epiphysis, the metaphysis, and the diaphysis. Diaphysis is the long shaft. Metaphysis is where the growth plate is found. This here shows the epiphyseal line in which the growth plate tends to eventually kind of fibrose and then form into an epiphyseal line. Then the epiphysis is usually what contains or constitutes as the head and the neck of the bone. And this is where the bone generally tends to form a articulation with another bone or a joint. Right. So the extent of the fracture. This is the second way in which we can classify fractures. A fracture can be classified based on its extent. So we have 2 types. We have a complete fracture, which is shown in this picture on the left, is that there is the entirety of the bone is being has been cut through or broken through, whereas incomplete, as shown here, is a fracture in which there is still portions of the bone which remain or maintain some form of union between both fragments. However, there is a disruption in the overall integrity of the bone itself. In terms of orientation of the fracture, fractures can also be classified based on orientation, so fractures generally tend on 3D. They are not 2-dimensional. And the way in which we generally tend look at fractures is both from an anteroposterior view and a lateral view. So the way in which we can we can see fractures, or we can visualize fractures in a transverse way, in which there is a horizontal based fracture, an oblique fracture, which basically means it is diagonal, going from further from the top to the bottom, or vice versa. Spiral, in which the fracture generally starts to form in a spiralized shape. So you'll see fragments kind of hooking around each other like so. And longitudinal, which isn't shown in any of the pictures to the right, I'm afraid, but is a fracture which generally tends to span from the top downwards to the bottom. Right. Displacement of a fracture. So a fracture can either be displaced, non-displaced, and angulated. So a non-displaced fracture is a fracture in which the two key segments, which generally form a general union of the bone, are still in line with one another. A displaced fracture is when the fracture fragments are no longer in line with one another. So as you can see in this side on the right, you can see that both bone fragments are no longer in the same orientation, are no longer following the exact alignment in which the bone generally tends to follow, unlike the non-displaced fracture on the left, in which there is obviously some loss of union, or there is disruption to the uniformity of the bone. However, the angle and the orientation of the fragments generally tends to maintain, or it is generally similar to the original of the bone. Angulated. Sometimes we have fragments of bone which generally tend to form an angle from the general orientation. So as you can see here, not only is this bone displaced, however, there is some angulation as well, because the orientation of the distal portion of the bone is going at an angle as opposed to continuing with the general orientation that the bone generally follows. And here we have fragmentation. So a fracture can also be classified based on fragments. Butterfly fragmentation is shown on the left. The reason why we call it butterfly fragmentation is that we notice that these fragments here, as indicated by my cursor, generally tend to follow a butterfly wing kind of shape. A comminuted fragmentation is generally when there is a fracture which has caused multiple little fractures to kind of form along the length of the bone. It's generally referred to as a shatter in the bone. So you have multiple tiny pieces which are kind of dispersed within kind of the bone. Then you have segmental fragmentation. So segmental fragmentation would be a situation in which, similar to the one on the right, where there are multiple segments and there are two segments with a piece of bone in the middle, which is no longer attached as shown here. Now, soft tissue involvement. This would probably be one of the more important classifications that are important to know. So fractures may also be classified based on soft tissue involvement. We have closed fractures and we have open fractures. Closed fractures are generally known as simple fractures, in which there is no tissue and soft tissue involvement at all. The bone generally isn't massively displaced, and therefore that does not interrupt any of the soft tissue nearby. However, open fractures generally result in disruption or angulation of the bone. The bone is no longer going in the exact orientation in which it should be following, and therefore tends to penetrate the soft tissue. Therefore, it is known as an open fracture or a compound fracture. So classification of open fractures. Open fractures are generally classified using a system known as the Gustilo and Anderson classification. And this is a table which summarizes the Gustilo and Anderson classification. So grade 1 goes and spans through to grade 3C. Grade 1 obviously being the milder end of the spectrum, whereas 3C being when things are a little bit more serious. So grade 1 means that it is a low energy wound. Soft tissue involvement is less than 1 centimeter wide. Whereas grade 2, it is a greater energy wound, greater than 1 centimeter, and there is moderate soft tissue injury involved. Grade 3 means that is usually a high energy wound in which there is a large portion of soft tissue injury, and there is obviously accompanying severe soft tissue injury as shown in the pictures from the middle throughout to the right. So 3A indicates that there is adequate soft tissue coverage. So despite the fact that there is an open fracture with the bone passing out through the soft tissue, generally what we tend to find is that the bone is more so, or the integrity of kind of the injured limb has some kind of covering or is encapsulated within the soft tissue still. 3B means that there is inadequate soft tissue coverage. So the bone generally has little to no protection. And 3C generally indicates that there is associated arterial involvement. So the arterial supply within the within the limb has also been damaged by the actual fracture itself. This is important not only for grading purposes or using for classifications, but also because it indicates severity along the bone fracture. It is important to remember that compound fractures are going to be more susceptible or more prone to infections naturally due to the nature of these fractures being uncovered or more open. We would tend to be a bit more worried, obviously, about a 3B fracture in which there is inadequate soft tissue coverage and there is a high severity injury or a high energy wound, as opposed to a low energy wound as indicated by grade 1. This is not to say that grade 1 is not serious. It is still an open fracture at the end of the day. So, what are the clinical features of a fracture? This is fairly straightforward. If you generally tend to think about a fracture, like we said before, is a loss of union. So if there is a loss of union, naturally what we'll see is that there will be a painful erythematous swelling at the site of the fracture. So there would be redness swelling along the site of the fracture itself. Deformity and axis deviation. So what we'd see is this kind of relates back to the angulation of the fragments of the bone. Fragments penetrating the skin. If it's an open fracture, we'll see portions of bone passing through the actual soft tissue. A palpable gap. This is only natural as there is loss of continuity of the bone. And potential neurovascular compromise. If there is nearby structures, such as an artery, a vein, or a nerve, there is a chance that a fracture may cause neurovascular compromise. And this is when things are a little bit more serious. Going back to the Gustillo and Anderson classification, associated arterial involvement is potential, it constitutes or it comes under the umbrella of neurovascular compromise, and therefore is something that we need to be a little bit more mindful of. So how do we investigate fractures? So fractures are generally quite straightforward to investigate. X-rays, 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 always first line for all fractures. Generally, it is what is recommended. However, it's also important to remember that fractures are not 2D, they are 3D, and a bone is also a 3D portion of the body. So the way in which we should image fractures is that we tend to do an anterior-posterior imaging, in which we take a look front to back, and a lateral as well, so that we can visualize the entirety of the bone in a 3D manner. So general management of fractures. So this is the general management pathway of fractures. Firstly, we'd like to start off with wound treatment. It's important that we start off with wound treatment because there may need some form of debridement around the site of injury. Pain management. We're not going to keep the patient in pain. One of your key jobs as an F1 doctor is going to be pain management. So this consists of both opioid and non-opioid analgesics. Examples of opioid analgesics would be things such as codeine, tramadol, dihydrocodone, etc. Non-opioid analgesia would be taking a look at things such as non-steroidal anti-inflammatory drugs, such as ibuprofen or celecoxib, which is more of a COX-1 inhibitor. So fracture care. So it's conservative or surgical. So generally what we tend to find is that there is three stages for fracture care. The two key stages are anatomical reduction and surgical fixation. So reduction is the process in which we bring the two fragments or the two pieces of bone closer back together. This can either be done in an open manner or a closed manner. An open manner generally indicates that there has been an incision made and we are surgically exposing the bone fragments in such a way that we are able to bring the two pieces closer together. Before we tend to do fixation, we generally tend to do reduction by bringing the pieces back together first. Closed can be done by bone manipulation without surgery. If you go and take a look at any orthopedic surgery, or if you've gone and looked at orthopedic surgery in the past, what you'll notice is that some surgeons tend to opt to not do open reduction and can opt to do things such as closed reduction, and by manually manipulating the pieces of bone and bringing them closer together. Surgical fixation is either internal or external. External indicates the use of frames to stabilize the bone, as shown on the right, whereas internal means that we are using methods such as plates or screws within the bone to stabilize it. So this on the right is known as an Ilezerov frame. It was a technique pioneered by Ilazarov, and it's a process which involves using forces and stresses on bone to regrow bone by providing a scaffolding structure around the actual bone which is damaged. What you'll see here is pieces of sponge. What's below that would be pins which will be attached directly to the bone itself and then covered so that to reduce infection. What you generally tend to find is that there is a risk of infection in these kinds of patients, as you are, especially if it's cutaneous infections. Immobilization. So all fractures should be immobilized during the proximal, including the proximal and distal joint. So if you have a fracture, for example, along the forearm, you would want to immobilize the wrist and also immobilize the elbow. Carefully monitor neurovascular status following immobilization. It's always important to make sure that there is no arterial, venous, or nerve injury. It's more serious when things involve arterial or nervous injury. And then finally, to conclude, would be tetanus prophylaxis, which is usually recommended. Now, there are specific additional measures for open fractures generally. So broad spectrum antibiotics. This is to target any bacteria which may cause an infection and may cause permanent destruction to the bone. We need to make sure that it's thoroughly debrided, and open fractures generally should be debrided and lavaged within 6 hours. Class 3C, as mentioned prior in the Costello and Anderson classification, where there is arterial involvement, usually needs an amputation if not managed correctly soon. It usually involves input from vascular surgeons prior to orthopedics. Thank you very much for watching part 1 of my series. This is focused generally on fractures, classification of fractures, investigations, clinical features, and general management of fractures. Part 2, we will be looking at examples of eponymous fractures.
I definitely feel I know more of fractures. How about you? So next we're going to be moving on to Callie's upper limb fracture talk. Enjoy!
So hello everyone, my name is Khaled Hashimi. I'm a recent graduate doctor this year, summer 2020, and today I'll be talking about orthopedic fractures. This is the second part of a small mini web series by SDocs, of which there are 3 parts. So if you've missed the first part, I'd recommend you go back before starting this one. If you would like to see some of my colleagues' lectures they are producing, do click on any of the other videos on this channel. Please do be sure to make sure that you check out part 1 and part 3 of this video, which you can find in the description of this video below. Please like and subscribe to the Medics Academy YouTube channel. And if you are a medical student, feel free to sign up for the free SDocs program, which you can do so from the link in the description of the video. Right, so part 2 of my mini web series will be focusing at specific types of eponymous fractures that are important to know at an undergraduate level for your exams. So part 2, types of fractures. We're going to start off with clavicular fractures. So generally what I'd do is I'd start with focusing on the upper limb and start moving down towards the lower limb. However, there are some odd ones out, such as clavicular fractures. So clavicular fractures, as the name obviously says, it's a fracture of the clavicle, and it's more commonly seen in children. The most common types are mid-shaft clavicular fractures. And the way that we classify them is shown below in this table here. So grade 1 is the middle shaft, which is the middle 1/3. And this is the majority of the cases, or 69% of the cases. The second most common is the distal 1/3 shaft fractures, in which is closer towards the acromioclavicular joint. And the proximal 1/3, which is attached at the sternum, rarely has any fractures, only 3% of fractures. This, as mentioned, it predominantly affects children and is typically seen in adolescents and teenagers. So the general causes of this are direct falls on the shoulder or direct trauma to the shoulder. You can imagine someone playing a contact sport such as rugby is prone to things such as a clavicular fracture. Foosh, which is a fall on an outstretched hand, is also a cause for clavicular fractures. However, makes up less than 10%. You'll tend to find that throughout this lecture that foosh will make up the majority of the causes for different fractures along the way. So we discussed the clinical features of fractures generally in my last video. and we will be repeating them. The things that I've noted in purple are the most important things that I'd recommend that you take away from this video. It's generally quite obvious that you would expect the clavicle to be painful with some erythematous swelling at the site of the fracture. There may also be some displacement and misalignment of the two fragments of the clavicle. Tenting of the skin above the fracture. So generally here, what you see here is a mid-shaft fracture, which is a grade 1. You'll see that there will be tenting, it's likely that there will be tenting of the skin as the proximal portion is angulated upwards, pressing along the skin just above the clavicle, and therefore it forms a tent. There's also elevation of the acromioclavicular joint, as shown here, due to tearing of the acromioclavicular ligaments surrounding the clavicle. And then you will also see that there will be shortening of the clavicle. The reason why there is shortening is because you tend to see that the pectoralis muscle starts to pull on the scapulohumeral joint, which is found obviously at the back of your shoulder and the top of your humerus. And generally what it causes is medial displacement of the lateral clavicular fragment, bringing it more medially, and therefore as a result, it will seem as if the clavicle is actually shorter than usual. The management that we generally tend to recommend for clavicular fractures is either conservative or surgical. Conservative would involve the use of a shoulder sling, and it's probably more recommended for cases in which there is not that much displacement. Surgical, excessively shortened or displaced, we do tension banding or use a clavicular plate. Humeral fractures. Humeral fractures are fractures of the humerus. They are classified as proximal, diaphyseal, and distal. The most common in elderly patients are the proximal. The diaphyseal or the shaft fractures are themselves classified into 1/3. So a proximal 1/3, a middle 1/3, and a distal 1/3. The most important one to remember for a shaft fracture is the distal 1/3. The reason for this is because it is known as a Holstein-Lewis fracture. A Holstein-Lewis fracture is the fracture of the distal 1/3 or distal third of the shaft. And generally, the reason why it's important is because that the radial nerve tends to wrap around the humerus following the radial groove, closer towards the distal portion of the shaft. Therefore, a fracture there also causes potential palsy by damaging the nearby radial nerve. It can also be classified according to comminution. Distal fractures are also quite important. You can have a fracture of the epicondyles of the distal portions of the humerus. However, more importantly to remember is a supracondylar fracture, which is the most common pediatric elbow fracture. Here is a picture of a supracondylar fracture. So generally what we tend to see is that these cases generally tend to affect elderly patients with osteoporosis. It's more common in females. The etiology is direct or indirect trauma, and the clinical features are there would be painful erythematous swelling at the site, as mentioned prior, displacement of the bone fragments, and bone fragments can also be noticed if this is an open fracture. There is a potential risk of neurovascular compromise, which always needs to be remembered. In the Holstein-Lewis fracture, as mentioned earlier, there is a risk of radial nerve injury. In a supracondylar fracture or a distal fracture, there is a risk of the brachial artery being perforated, especially as seen, and so the brachial artery would run generally around here. And if there was an injury there, it is likely that there would be a perforation of this artery. This can be quite worrying. So the investigations of almost every fracture is always an X-ray. The proximal and shaft fractures have normal signs, whereas a distal supracondylar fracture generally tends to follow something called a Sale sign, which is shown here, an anterior fat pad sign and a posterior fat pad sign. If you zoom in on the picture shown here, what you'll see is that there is black opacities kind of in front of and behind the elbow. These represent the anterior fat pad and the posterior fat pad. Management, conservative therapy, non-displaced closed fractures. And then there is also surgical intervention in open and displaced, and also in cases of neurovascular compromise, such as the supracondylar or the Holstein-Lewis fracture. For that, we tend to use IM nails or plating. So now we will take a look at distal radial fractures. These are some of the most important fractures that I'd recommend learning for your exams. There are 4 main types that we recommend: Colles fracture, Smith's fracture, which is a reverse Colles fracture, a Galeazzi fracture, which is a fracture of the distal radius with subsequent distal radial ulnar joint dislocation, and a Barton's fracture, which is similar to a Colles fracture. However, it subdivided itself into 2 types, and it's an interarticular fracture of the distal radius. So Colles fracture is shown here on the right. It's also known as a dinner fork deformity. It's usually the product of falling onto an outstretched hand. So Fuchs generally is responsible for a Colles fracture. What we see is that the fracture results in hyperextension of the hand at the wrist. The fragment is usually radially and dorsally displaced. If you take a look at the hand, this is the palmar aspect and this is the dorsal aspect. So there will be dorsal displacement of the bone, and it would usually be radially displaced, closer towards the radial bone itself. Now, so the clinical features and why this is important is that there would be painfully erythematous, as with all fractures, impaired range of motion at the wrist. This is to be expected, especially because there is damage or injury close towards the distal, at the distal radius, close to the actual radiocarpal joint. And you will see that the fragment is dorsally and radially displaced with some dorsal angulation too. An X-ray would generally tend to show everything that was just mentioned earlier. So the management, closed reduction is an option in these patients as it isn't always necessary for surgical manipulation of the bone fragment. If we have two simple bone fragments which fit right back into place, closed reduction can be, we can opt for closed reduction. However, surgical intervention is usually performed when the fracture is usually massively displaced. For that, we tend to involve the use of Kershaw wires, also known as K wires, which are inserted percutaneously in order to achieve fixation. Here is a picture of a dinner fork. You can see the resemblance between the dinner fork here and the Colles fracture. The Smith's fracture. This is also known as a reverse Colles fracture. This is also a distal radial fracture, and however, the fragment this time is usually radially and ventrally displaced. Ventral also means it's displaced towards the palmar aspect. This fracture is also referred to as a garden spade deformity. It is the product of a Fuchs in which we fall onto our outstretched hand backwards. It's important to remember backwards. Clinical features is that it's painful and erythematous, loss of motion, especially at the radiocarpal joint, also known as the wrist, and radially and ventrally displaced, plus volar angulation or palmar angulation to give the garden spade deformity. The investigation would be an X-ray, and the management would be closed reduction. Surgical manipulation isn't always necessary. Surgical intervention, we can also use percutaneous Kershaw wires in this case as well. This is usually recommended when articular involvement at the wrist occurs. Galeazzi fracture. So a Galeazzi fracture may be one of the more interesting types of fractures. A Galeazzi fracture, again, is also to a distal radial fracture, and it's the radial shaft fracture. However, it also results in a subsequent distal radio-ulnar joint dislocation. So it's important to remember that there are two radio-ulnar joints. There is a proximal radio-ulnar joint and a distal radio-ulnar joint. The distal radio-ulnar joint is usually interrupted in a Galeazzi fracture. The proximal radio-ulnar joint is usually disrupted in a Monteggia fracture. We'll come back to this soon shortly. So Galeazzi fractures tend to affect children more commonly. It again is also the product of a Fuchs. However, there is a rotational force which is generally superimposed. It is likely that you may potentially see a spiral-based fracture as a result of this. So there are clinical features: painful erythematous swelling at the distal radial site, impaired range of motion of the distal radius and the wrist joint, and there is also an anterior interosseous nerve palsy. So what is the anterior interosseous nerve? The anterior interosseous nerve is a purely motor branch of the median nerve, and damage to this nerve results in motor paralysis of muscles located within the flexor compartment, and thus you are unable to make an OK sign with their thumb and finger. If you take a look at the picture on the top left, you'll notice that this is the normal, showing a normal OK sign, and this is an anterior interosseous nerve palsy. It's like mentioned, it's responsible for innervation of muscles within the flexor compartment, particularly the flexor pollicis longus, pronator quadratus, and flexor digitorum profundus. The flexor pollicis longus is located directly below the flexor carpi radialis, and below that would be the pronator quadratus. That's just a tip that you might want to remember for your spotter exams. So the investigation would be an X-ray again, and it would show, as mentioned, a distal radial shaft fracture with radio-ulnar joint dislocation or disruption. And management, since there is not much place for conservative management, surgeons would have to opt for surgical intervention because it is complicated and there is also intra-articular involvement seen. So therefore, we would tend to opt for an ORIF approach, known as an open reduction internal fixation, using K wires and plating. Here is a picture of the arm. Here also we can take a look, and we are also able to see that this is the median nerve coming from the brachial plexus. And here is the anterior interosseous nerve, which is a branch. This will continue downwards until it innervates the three muscles that were mentioned earlier. Those muscles, just to recap, are the flexor pollicis longus and the pronator quadratus, which are found directly below the FCR, the flexor carpi radialis, and also the flexor digitorum profundus. A Barton's fracture. A Barton's fracture may appear slightly similar to a Colles fracture and Smith's fracture, and might actually be slightly confusing as well. However, it is a distal intra-articular fracture involving the radiocarpal joint. So it is at the wrist. It leads to radiocarpal dislocation between the radius and the carpal bones of the wrist. There are two types. There is a dorsal type, and there is a palmar or a volar type. The volar type involves volar displacement of the intra-articular distal radius. And then a dorsal Barton fracture is dorsal displacement of the intra-articular distal radius. So you can see it here in this picture. You can see that this is a dorsal fracture. It's similar to a Colles fracture. However, if you took a look very closely, a Colles fracture is a fracture through more so the bone with no intra-articular involvement, whereas a Barton fracture has some intra-articular involvement itself. The same could be said between a Smith and a palmar or a reverse Barton fracture. Again, this is usually caused by a fouche falling onto an outstretched hand, extended elbow with a pronated arm. Clinical features: painful erythematous swelling at the distal radial site and loss of range of motion at the wrist. The investigations again would be an X-ray, which would show you an intra-articular fracture, which is unlikely seen to be in a Colles or a Smith fracture. The management: this is very difficult that we'd be able to do conservative management. Usually we have to opt for surgical because it's hard to carry out surgical fixation with the radiocarpal dislocation. Therefore, ORIF is what we tend to opt for. A Hutchinson's fracture or a chauffeur's fracture. So it's an intra-articular fracture of the radial styloid. It's also known as a chauffeur's fracture. The etiology is due to a fouche once again. And then you have repeated forces. These are continuous forces which cause compression of the scaphoid against the radial styloid process. The radial styloid process and the scaphoid are adjacent to one another. Therefore, if you have some form of forces repeatedly pressing against it, it's likely that a fragile fragment like the radial styloid process would become dislodged itself. Clinical features: painful erythematous at the site of fracture and wrist pain. So you would obviously have pain at the wrist. Displacement is rarely seen. That's because the radial styloid is only a small fragment, and therefore it's unlikely that we'll see much displacement at all. The investigations: we would have an X-ray again. And the management, we would tend to go for either conservative, because there isn't that much displacement, as mentioned prior. So therefore we could go for a Colles type plaster, or surgical. If there is massive displacement, only cases of extreme displacement, then we would opt for ORIF. Ulnar fractures. This too is also an interesting fracture, similar to a Galeazzi fracture. And what I'd recommend is that you learn the differentiation between the two, as there are some similarities in terms of the complications that you may want to remember just for exams. So Monteggia's fracture is the most important one to remember. A Monteggia fracture is a proximal 1/3 of the ulnar fracture with subsequent dislocation of the proximal radio-ulnar joint. This is more common in children. So this is brought about again by a fouche. What we have is similar clinical features as with all fractures, such as inability to move out the elbow and painful erythematous swelling. The most important thing to take away from this would be a posterior interosseous nerve palsy. Please note that in the previous fracture, which was the Galeazzi's fracture, sorry, it was an anterior interosseous nerve palsy, whereas with the Monteggia's fracture, it is a posterior interosseous nerve palsy. This is an important point to remember. The posterior interosseous nerve is a nerve that is a branch of the radial nerve, which wraps around the posterior end and innervates usually the extensor compartments and also the triceps and posterior parts of the arm. It is a motor nerve, and it results in a motor paralysis of the muscles located within the extensor compartment. Thus, patients generally tend to struggle with extension of their thumb and their fingers at the MCP joints. Metacarpophalangeal joints are also known as the knuckles. I would recommend that you remember this. You can see here that this is the radial nerve. The radial nerve tends to pass through the arcade of Frost. The arcade of Frost is brought about by passing underneath the thickened heads of the supinator muscle within the extensor compartment. As mentioned, it is a motor nerve and it's responsible for motor innervation. Therefore, we usually results in paralysis of the muscles within the extensor compartment, and subsequently we're not able to move our fingers or our thumb. So the management, we would use closed reduction and casting in children, and in adults we tend to opt for ORIF. This is the same in cases where the fractures are complex, such as there is large amounts of displacement, or when there is also situations such as neurovascular compromise. Carpal fractures. These are the most important one to take away from today would be a scaphoid fracture, and that's the one that I'm going to be teaching you. So, a scaphoid fracture. A scaphoid fracture is actually a fracture of the scaphoid bone, which is located within the wrist. It is one of the carpal bones. It is also important that here is a small recap of the bones within the wrist. So the scaphoid, the lunate, the triquetrum, the pisiform, the trapezium, the trapezoid, the capitate, and the hamate. You can remember this with the interesting saying that medics tend to usually enjoy using. Some lovers try positions they truly can't handle. Little bit crude, but can be very useful to remember things like this in an exam. Here is the scaphoid. Most commonly located, the fractures of the scaphoid bone usually occur in the middle 1/3 of the scaphoid bone. It's more common in males, generally tend to see in early 20s, and it's usually noticed in patients who do contact sports. It can also be a product of a Fuchs injury once again, where the wrist is hyperextended. This is flexion, and this is extension. Hyperextension would be when there is excessive extension past the point in which it would be a little bit more worrying. It's more likely to present on Mondays and less so on the weekends. It's believed the reason for this is when patients are out consuming alcohol or a little bit more intoxicated, have a little bit of an injury over the weekend, and more likely to come in on a Monday. So, the clinical features of this. Pain when pressing on the anatomical snuff box plus the scaphoid tubercle. The anatomical snuff box is a structure which is located close to the radial artery and adjacent to the scaphoid. It is the product of 3 tendons: the extensor pollicis longus, the abductor pollicis brevis, the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus. I would recommend that you remember this. There is also a risk of joint effusion. This is more likely to be seen in hyperacute settings, where it's less likely to be seen in hyperacute settings, whereby it's less than 4 hours old since the fracture, or in cases whereby we have left the fracture for a delayed period of time, which is greater than 4 days. That we generally tend to find that is painful pinching, grasping, and there's also decreased grip strength. If we also compress the thumb, you'll tend to find that there is pain at the same place mentioned earlier. There is limited decrease in movement unless displaced. The investigations. The first line, as usual, is in an X-ray. As mentioned prior, we tend to opt to use AP and lateral views of the wrist on the X-ray. 25% of these fractures cannot actually be visualized on X-ray, so therefore we must repeat them within 2 weeks when a scaphoid is diagnosed or when X-ray is inconclusive. Second line that we can opt for is CT. However, MRI is usually the definitive investigation, and therefore we may opt to use this second line as opposed to CT. The CT, however, is better than X-ray, is used for preoperative planning and also determines the extent of union during follow-up. Management, conservative or surgical. Management generally conservative management is if there is a non-displaced fracture, which is less than 1 millimeter, and we use a Spica cast for 4 to 6 weeks. Surgery is usually opted for if there is neurovascular compromise or extensive displacement. Screw placement is the mainstay of treatment. If you take a look at the photo here, what you can see is a screw that has been passed through the scaphoid along the fracture line and therefore is used to stabilize the bone. That concludes part 2 of my lectures on orthopedic fractures. Stay tuned for part 3 or follow the link in the description below so that you are able to continue watching part 3. Thank you very much.
Callie definitely did a great job on those talks, don't you think? So next we're going to be having a talk from Adeolu, who's going to be talking us through left to right shuns. So get excited, guys.
So hello, I'm Adiolu, and I'm going to be delivering this talk on congenital heart disease. Just before I start, if you want to see any of the other videos that are being produced, do click on any of the other videos on this channel. Make sure to check out part 2 of this video, which you can find in the description below. And please like and subscribe to the Medics Academy YouTube channel to get notified about future videos as our content is consistently updated. And also, if you're a medical student, sign up to the free SDocs program, which you can do so from the link in the description below. So now on to the teach on congenital heart disease. Okay, so just as an overview of what I'm going to be covering, the first part of this video will be on left to right shunts. Then I'm going to be going on to right to left shunts, or the 5 T's, and then I'll end off with coarctation of the aorta and also some case studies as well. So first, starting off with left to right shunts. So a left to right shunt is basically a hole or any form of abnormal connection between the left side of the heart and the right side of the heart. So blood obviously flows from high pressure side, which is the left side, to the low pressure side, which is the right side, through the hole. So this would result in a non-cyanotic baby, basically. So the baby would be pink, the baby wouldn't be blue, and you might not be able to detect that there was a shunt immediately because the baby might not be symptoms right off the bat, might not have symptoms right off the bat. So what happens with a left to right shunt is that it's more of a progressive picture. So you start to get increased pulmonary arterial flow because you have that pressure going from the left side of the heart to the right side of the heart. You start to get increased pressure in the pulmonary artery, and this results in increased resistance in the pulmonary artery because the pulmonary vasculature will basically change its normal anatomy in response to this increased flow. All of these 3 things end up causing pulmonary hypertension, and this leads to a syndrome called Eisenmenger syndrome. So Eisenmenger syndrome can present with late cyanosis. So again, the baby, when it's just born, won't be cyanosed, but in a couple of years, the cyanosis could then develop. It can also present with clubbing, which you can see in the photo on the screen, and also something called polycythemia, which is just an elevated hemoglobin level. And the age of onset, again, can vary depending on kind of the size of the hole and how quickly you get that pulmonary hypertension developing. So now starting off with an example of a left to right shunt, which is the most common congenital heart disease that you can get, which is an ASD, or an atrial septal defect. So an atrial septal defect is a hole in the atrial septum causing a left to right shunt of oxygenated blood. There's 2 types of ASDs. There's an ostium secundum, which is in the mid-septum. So that's kind of what's demonstrated in the picture there. And that is the way more common form of ASD. There's also an ostium primum ASD, which is going to be lower in the septum. So the usual presentation of an ASD is that it can actually be diagnosed at any age because it's often screened for. You get that 6-week screen after any baby is born, and oftentimes that can be when you diagnose the ASD for the first time, or it could also be diagnosed later on in life. An asymptomatic child will often have a murmur. However, in terms of actual symptoms, most ASDs won't present symptomatically and will rather present in screening. And that's just because the atria are low pressure symptoms. So the amount of blood that's actually shunting through that hole is going to be very, very small. So the answer for the question on the screen, how does an ASD usually present, is it'll basically be C, so breathlessness in middle age due to pulmonary hypertension. And that's because you won't get symptoms until that kind of older age. So in order to diagnose an ASD, you want to be listening for a murmur, and the typical murmur would be a fixed split S2 murmur. And you can also have a mild systolic ejection murmur over the pulmonary area of the heart, which you can see in that image there. But the actual diagnosis would be with an echo, or you can do a bubble study as well, which is a different way of diagnosing an ASD. And this slide just kind of explains what the split S2 actually means. So what you have with an ASD is you have fixed splitting, which is where your S2 sound, which is like your second, the dub after the lub dub, will always be split, whether it's on inspiration or expiration. Whereas normally you would get a splitting in inspiration, but not an expiration. So that's the difference between like normal and pathologic, potentially an ASD, is that that splitting will be fixed and will happen all the time, regardless of inspiration or expiration. So now for treatment, if it's a small ASD and the patient is asymptomatic, you can actually just leave it. But if they are symptomatic or the ASD is a lot larger, you can close usually with a catheter. And so the question below is, which of the following is not a complication of an ASD? And the answer is endocarditis. And that's because that's a more common complication of VSDs. And that's just because the higher velocity of flow in the ventricles versus the atria increases your risk of clot formation, which then attracts bacteria. And the other three kind of have already been discussed. AF is more common just because your increased blood in the atria causes stretching of the atria. And when they stretch, you can then get that abnormal contraction, which is basically your fibrillation. Pulmonary hypertension is again just because of that increased blood flow onto the right side of the heart. And stroke in under 40s is because if you have a DVT that then crosses your ASD, that can cause a stroke. And so it's a common cause of stroke, especially in younger patients. So next, I'm going to be talking about ventricular septal defects, or VSDs. So these usually present in, this is a hole or an abnormal connection between the two ventricles. The physiology is similar to that of an ASD, but everything is just more increased because there's higher pressures. So it usually presents in the first year of life because, again, the higher pressures mean you'll get earlier symptomatic presentation. It'll either present with a murmur or asymptomatically, and it's associated with Down syndrome. So to diagnose a VSD, you're going to have, so for that question, the answer is going to be C. You're going to have a continuous, harsh sounding systolic murmur. For your treatment of VSDs, and it's going to be loudest at the tricuspid area. So for your treatment of VSDs, you're going to potentially repair it. Some VSDs will close on their own, especially within the first year of life. But if you wait and the VSD is not closing, you'd want to repair it with either a catheter or with surgery, depending on the size and the location of the VSD. The complications of ventricular septal defects are very similar to those of atrial septal defects, but there's the added increased risk of endocarditis as well. So next, we're going to be covering patent ductus arteriosus. So rather than a hole between the atrial septum or the ventricular septum, a patent ductus arteriosus is when there's persistence of this duct, which you can see between the pulmonary artery and the aorta. So this duct is normal as in fetal life, so before the baby's born, and that's how the baby gets oxygenated blood to its descending aorta and its lower body. But it's not normal to persist after fetal life. So the pathology starts when this duct doesn't close up right after the baby is born. And this kind of shows again how the duct is essential in fetal life because it gets the descending aorta oxygenated blood. So the presentation for this congenital heart defect is you'll have a continuous machine-like murmur that will be best heard at the left infraclavicular area. You can also get cyanosis of the lower extremities in particular, because those would be the extremities that would be getting the deoxygenated blood, and it's also associated with rubella and prematurity. So to diagnose, you use an echo, same as you would use for the atrial septal defects and the ventricular septal defects. And what is the first line treatment? So the first line treatment is actually A, NSAIDs, and that's because those help close close PDAs. However, if you have a particularly large PDA, then you might need surgical intervention, and prostaglandins are actually what maintain PDAs. So for some forms of congenital heart disease, if you actually want the duct to stay open, then you would use prostaglandins, but to close them, you would use NSAIDs, particularly an NSAID called endomethacin. And that is the end of this part of the talk.
So after left to right shunts, you guessed it, we're moving on to right to left shunts. I'm looking forward to it. You should be too.
Hello, so this is part 2 of the 3-part congenital heart disease talk. So if you would like to see any of the other lectures that are being produced by my colleagues, do click on any of the other videos of this channel. Make sure you check out part 3 of this video afterwards, and if you haven't seen part 1 yet, check that out first and come back. And please like and subscribe to the Medics Academy YouTube channel to get notified about future videos as our content is consistently updated. And if you're a medical student, please sign up for the free SDocs program, which you can find out about in the link in the description below. So now on to part 2 of the congenital heart disease talk, which is on right to left shunts. So there are 5 different kinds of right to left shunts. And an easy way of remembering them is just to use the 5 T's. So you have tetralogy of Fallot, transposition of the great arteries, which are the 2 most common right to left shunts. And then the other 3 are, you can think of that for a second, and they are truncus, total anomalous pulmonary venous return, and tricuspid atresia. But for this lecture, we're going to be mainly focusing on the first 2, tetralogy and transposition, because those are way more common than the other ones. So what is a right to left shunt? So a right to left shunt is basically when you have blood flowing across a defect from the right side of the heart to the left side of the heart. And because it's flowing from the right side to the left side, it's not being oxygenated. So it's not going through the lungs, through the pulmonary arteries to get oxygen. So you basically have deoxygenated blood flowing to the periphery or to the body. And this is what will cause a cyanotic or a blue baby that from birth will be blue and will be breathless right away. And so this is much more of a medical emergency than a left to right shunt. And these are the babies that will die without immediate intervention. So the first example of a right to left shunt is transposition of the great arteries. So in a regular transposition of the great arteries, or TGA for short, you have 2 separate systems that form. So the vena cava, which is here, your SVC and your IVC, they connect directly to the aorta with no oxygenation from the lungs. So that causes deoxygenated blood to flow to the entire body. And then your pulmonary veins connect to your pulmonary artery with no access to your body. So your blood is being oxygenated, but that's not connecting to your body. And the blood that is going to your body is not getting any oxygen. So this is often diagnosed prenatally due to fetal screening, so that you're able to intervene as soon as the baby is born. So to diagnose a transposition of the great arteries, you would use an echo and try to diagnose it for the 20-week fetal anomaly screen. And on echo, what you tend to see is you see that the 2 vessels, so the AO is aorta and the PT is the pulmonary trunk, and those 2 vessels will be parallel to each other rather than crossing, which is what normally happens. And transposition of the great arteries is associated with mothers with diabetes. So this is not gestational diabetes, but diabetes before you're pregnant. So in order to manage a baby with a transposition of the great arteries, in order for them to even survive before you intervene, they usually have a large ASD or a patent ductus arteriosus. So just in case, the immediate treatment for any baby diagnosed with a TGA is to give them prostaglandins to make sure that their duct stays open, because that duct is the only thing that's causing oxygenated blood to get to their body. And then your eventual treatment would be something called an arterial switch procedure, which is an operation that would occur within the first couple days of life, where, as you can see from photo 2 and 3, you essentially cut off the bottom of the pulmonary trunk and the aorta, and you switch them with each other. So the next really common right to left shunt is a tetralogy of Fallot. It's called a tetralogy because there's 4 main features. And so the question is, which of the following is not one of the 4 characteristics of a tetralogy? And the answer is B, coarctation of the aorta. And that's because the 4 main features of a tetralogy is a VSD, a pulmonary stenosis, right ventricular hypertrophy, and an aorta overriding the VSD. So the presentation of a tetralogy of Fallot is that the stenosis of the pulmonary trunk causes right to left flow over the ventricular septal defect. So right here is the right side of the heart, and here is the left side of the heart. And because of the stenosis of the pulmonary artery, this causes there to be increased pressure on the right side versus the left side, which will cause deoxygenated blood flowing directly to the left side of the heart and to the body. So the severity of this disease is directly dependent on how stenosed this pulmonary trunk is. So what can happen is that because of that, you'll have a spectrum of tetralogy of Fallot. So you'll have some babies that have a really, really significant degree of stenosis that will be cyanotic at birth, or you'll have some babies that will have these things called cyanotic spells, where during crying or feeding, they'll basically turn blue. And that's because those times cause them to have increased work of the heart, which would then cause increased deoxygenated blood flowing, which would then make them turn blue. And tetralogy of Fallot is associated with DeGeorge syndrome and also fetal alcohol syndrome. And this is a photo of what like a cyanotic or a TET spell would look like. And so the question is, what improves TET spells, which is again a cyanotic spell caused by tetralogy? And the answer is B, squatting. And the reason why is because it increases your systemic vascular resistance, which then causes less blood to flow from the right side of the heart to the left side of the heart. So you get less deoxygenated blood flowing to the body. So to diagnose the tetralogy of Fallot, the definitive diagnosis would be using an echo. And this is another form of congenital heart disease, which is often diagnosed prenatally due to all the screening that should occur prenatally. So at the 20-week fetal anomaly screen, it should be ideally diagnosed then. And also on a chest X-ray, these patients would have a boot-shaped heart, which you can see in the image on the screen. For treatment, it's going to be a surgical treatment. And there's two different ways that you can treat tetralogy. You can either repair the pulmonary stenosis and patch the VSD, or you can do both stages of surgery at the same time and do a definitive repair right away. And so the different hospitals will do different forms of management. So it depends on what your local hospital does. And so then next I'm going to go through coarctation, and then the last part will be just the cases. So coarctation of the aorta is when you have a narrowing of the aorta, usually distal to the three great vessels coming off of it. So as you can see in this picture, it's after you have your three first branches. And what it presents with is hypertension in the upper extremities and hypotension in the lower extremities. And another sign that you can have is what's called radiofemoral delay, just because again of that delay of your femoral pulse versus your radial pulse. And you can also have symptoms of headache and leg fatigue. Headache is just because you're having so much blood going to your upper part of your body because of that narrowing that's distal to your vessels that lead to your head and neck. And leg fatigue is because your lower half of your body isn't getting enough blood, so you get fatigue. And this is associated with Turner syndrome. So to diagnose, you would again use an echo for definitive diagnosis, but in older patients that might have their coarctation missed, they would develop something called rib notching, which you would see on a chest X-ray. And that's just because you get increased intercostal vessels that start to bulge, and that's just to create another pathway from your top part of your aorta to your bottom half of your body. So the way you would treat a coarctation of the aorta is to repair it. So it can be done via catheter if possible, or it might need open surgery as well. But it's most commonly done via a catheter, which you can see kind of in the picture at the bottom. And that is the end of part 2 of the congenital heart disease talk.
For our final talk, Adiola will be going through clinical cases related to congenital heart defects. This is a perfect chance to put what you learned from Marie's talks into practice. Enjoy.
Hello, so this is part 3 out of the 3-part congenital heart disease teach. So if you want to see part 1 and part 2, click those videos first before you come to this part, which is the last one. If you want to see any of the other lectures that my colleagues are producing, then do click on any of the other videos of this channel. Please like and subscribe to the Medics Academy YouTube channel to get notified about future videos as our content is consistently updated. And if you're a medical student, sign up to the free SDocs program, which you can do so from the link in the description below. So now on to the last part, which is all just some clinical cases for you to apply the knowledge you've learned from part 1 and part 2. So the first case, case 1, a baby is born with obvious signs of cyanosis and distress that do not improve with oxygenation. You find out that the mother missed her 20-week fetal anomaly scan. What do you do first? So just kind of breaking down this case, you know that because the baby is immediately born with cyanosis and distress, that it's likely to be a right to left shunt. And because the mother missed her 20-week fetal anomaly scan, you know it's likely something that could have been diagnosed prenatally, but wasn't because she missed her screening. So she's probably coming with an undiagnosed congenital heart disease. So what you would want to do first is something that you can do immediately, regardless of what hospital the lady was born in, or even if it's in more of a community setting, which is prostaglandin. So you want to give prostaglandins immediately, because especially if this baby has a transposition of the great arteries, prostaglandins could be the only thing to keep them alive, because it will keep that duct between the arterial system and the pulmonary system open so that they're able to have some oxygenated blood going to the rest of their body. So your answer would be, first, give them prostaglandins just to give them time, and then you want to do an echo immediately to get a definitive diagnosis before then looking at surgery. Okay, so this is a continuation of that same case. So you give your prostaglandins first, then you perform an echo, and on echo you see parallel great vessels. So the question is, what operation is this baby likely to receive and when? So parallel great vessels is a sign of a transposition, so transposition of the great arteries. And so the operation that this baby will need is an arterial switch procedure. And these occur in the first week of life. So basically, as soon as you can do the procedure, you tend to just do it. And that's because these babies just won't do well before getting this procedure done. Okay, so now on to case 2. So a 6-month-old baby is well and thriving and is visiting their GP for a routine check. The GP detects a quiet systolic murmur over the pulmonary area of the chest. What is the most likely diagnosis? So this is quite different from the previous case because this baby is completely asymptomatic and is well and thriving, but the only sign is a quiet murmur over the pulmonary area of the chest. And so this is actually an atrial septal defect, or an ASD. So this is a left to right shunt instead of a right to left shunt, and that is why the baby is presenting asymptomatically, and the only sign is the murmur. And just remember how an ASD differs from a VSD, and that a VSD would have a harsh sounding systolic murmur, whereas an ASD has a more quiet murmur over the pulmonary area of the chest. So now the last case, which is case 3, a 2-year-old child is brought by a worried mom. The mom says she feels like the child's legs are always cold and the child is refusing to walk. What signs would you expect to find on investigation? So this one is actually a bit tricky, but the main kind of hint is that the child is refusing to walk and the child's legs are cold. Those are kind of 2 signs that the child's lower body might not be getting enough blood. So one thing you'd want to at least have on your differential list is a coarctation of the aorta. So for signs that you would expect to find on investigation, you would have a brachiofemoral delay, again, just feeling that brachial pulse, comparing it to the femoral pulse. And you would also find hypertension in the arms and hypotension in the legs. So that is the end of the congenital heart disease teach. These are my sources, and I want to thank all these resources for allowing me to put together this presentation. And these are the sources of the photos used in the presentation as well. So yeah, thank you for listening.
Whoa, that was fantastic. Thank you so much to Adeola, Marie, and Callie for their great work today. Remember to join the SDots Facebook group, the SDots Slack group, as well as join our Mets Academy YouTube channel to keep up to date with all the awesome content we have coming up. So thank you so much, guys, for supporting us for the last few months, and I hope you'll support us in the future and look forward to awesome events like these.